You've had chest pain for 3 days. Not crushing. Not the left arm kind you saw described when you Googled it the first time. Just pressure. A tightness that arrives in the morning and doesn't fully leave by night. You Googled it again yesterday, clicked the first result, read 2 paragraphs, closed the tab, because the next sentence was going to tell you to see a doctor, and you know what that costs. What happens next depends entirely on one number, not your age, not your zip code, your bank balance. 8 levels, 8 outcomes, same symptom, same artery. None of this is medical advice. No doctor-patient relationship is created by a YouTube channel. The numbers you're about to hear are real. What you do with them is yours. Healthcare is the single largest financial risk for 80% of American households. It is also the one risk that is almost entirely determined by how much money you already have. Level 1, no money. You don't have insurance. You haven't had it in 4 years, since the job that offered it ended. You looked at the marketplace plans once. The cheapest one in your state was $328 a month with a $7,500 deductible. The $328 is just for the right to have that deal. You couldn't afford either number. So when the chest pressure gets worse on day 4, you go to the emergency room, because the emergency room can't turn you away. That's the law. You wait 4 hours in a plastic chair. The triage nurse asks your pain level on a scale of 1 to 10. You say 6. She writes something down. You watch people go in and come out. You watch the clock. A doctor sees you for 9 minutes. She orders an EKG and a chest x-ray. She says everything looks normal. She says it could be costochondritis, inflammation of the cartilage where the ribs connect to the sternum. She says to follow up with a primary care physician. You don't have one. You don't say this. The bill arrives 3 weeks later. $1,847 for the visit, the EKG, and the x-ray. You apply for the hospital's financial assistance program. They reduce it to $400. You set up a payment plan, $40 a month for 10 months. The chest pressure comes back twice more that year. Both times you wait to see if it passes. Both times it does. The third time it doesn't. Level 2, $5,000. You don't go to the ER. You've learned that lesson. The ER is for emergencies you can prove in 9 minutes. This chest pressure, the tightness that showed up Tuesday and hasn't gone anywhere by Thursday, it won't look urgent enough on paper. It will cost $1,500 minimum and end with a referral you can't afford to follow. So you go to the urgent care on the corner. $175 for the visit. You put it on the credit card. The doctor is fast and thorough in the way that 12-minute appointments require. He listens to your heart, takes your blood pressure, 138/88, slightly elevated. Orders a basic metabolic panel, says it's probably stress, says to cut back on sodium, says if it gets worse, see a cardiologist. You ask how much a cardiologist costs. He doesn't know exactly. He says to call your insurance. You have a high deductible plan through a part-time job. The deductible is $4,000. A cardiology consultation out of pocket runs $300 to $500. The stress test they'd order runs another $800 to $1,200, depending on the facility. You do the math on the way home. You can't do it this month. You tell yourself you'll go next month when the credit card clears. Next month, you go back to urgent care because the pressure is back. Different doctor this time. She looks at your chart, sees the visit from 8 weeks ago, says the same thing about sodium. You are not being neglected. You are being treated correctly within a system designed to react to crises. The problem is that what's happening inside you is not yet a crisis. It will be, but not yet. and the system is not built to find things that aren't crises yet. You leave with a printout about the DASH diet. You put it in the glove compartment. Level 3. $20,000. You have a doctor, an actual doctor, not a rotating urgent care physician, not a triage nurse, not a website, a primary care physician who has your name in a file and has seen your face more than once. She's covered by your insurance. The copay is $40. The wait for a non-urgent appointment is 3 weeks. You've learned to schedule the next one before you leave the current one. At your annual physical, she takes a full history. She asks about your father. Did he have heart disease? You say you don't know. He died at 57. She pauses, writes that down. She orders a lipid panel. Your LDL comes back at 148. She says that's borderline. She recommends lifestyle changes first, then reassessment in 3 months. 3 months later, it's 142. Still borderline. She prescribes a low-dose statin. This is good medicine. It is also reactive medicine, responding to numbers that have already moved in the wrong direction, 1 marker at a time, 1 appointment at a time, 3 weeks between each data point. When you mention the chest pressure, she takes it seriously. She refers you to a cardiologist. The wait is 11 weeks. You go. He orders a treadmill stress test. You pass it. He says to continue the statin and come back if symptoms worsen. You leave the cardiologist's office with a normal result on a test that measures one thing. You are told to come back if symptoms worsen. The system is now waiting for your symptoms to worsen. You go home. You take the statin. You feel fine. Level 4. $75,000. The difference at this level isn't a better doctor. It's time. She remembers the chest pressure. You didn't remind her. She just remembers. Your primary care physician has 1,400 patients. At this income level, she has 900. The appointment that used to take 3 weeks takes 1. She spends 25 minutes with you instead of 12. She has time to notice the pattern, the blood pressure trend, the father who died at 57, the chest pressure that keeps returning, and treat it as a pattern rather than a series of individual complaints. She doesn't refer you to a cardiologist and send you into an 11-week wait. She refers you with a phone call to a colleague. You see the cardiologist in 2 weeks. He knows she sent you. He has the notes already. The stress test he orders is an echocardiogram stress test, not just a treadmill. You start getting a colonoscopy at 40 instead of 45 because your doctor has time to notice your family history and follow the guidelines that say to screen earlier when there's risk. You start getting a calcium score, a cardiac CT scan that detects plaque building up inside your arteries before symptoms appear. She has time to recommend it. It isn't something she orders for everyone. It's something she ordered because she looked at you as a whole. The calcium score comes back at 112. Not normal. Not an emergency. A signal that plaque is accumulating, identified years before it becomes a problem. You start a higher dose statin. You start low-dose aspirin. You change the diet with real intention this time. The chest pressure has a name now. It has a treatment plan. It has a follow-up date. Level 5. $200,000. At every level before this, the system was reacting. At this level, it starts watching. You pay $3,800 a year to be on your doctor's patient list. Not for visits, for access. The practice has 300 patients. A standard panel has 1,400. The math is the entire difference in the relationship. When you have chest pressure on a Tuesday morning, you call the direct line, not scheduling. The direct line, a voice answers. You describe what you're feeling. Your doctor says, come in at noon. She knows every medication you're on, not because she looked it up, because she remembers. She remembers the calcium score from last year was 112. She remembers that your father died at 57, and your brother had a stent placed at 54. She calls your cardiologist while you're sitting in her office. They talk for 8 minutes. The cardiologist's next opening is Friday. Your doctor says Thursday would be better. Thursday it is. The cardiologist orders a CT angiogram, a 3D map of your coronary arteries, rendered in high resolution. Not because something is wrong, because you have a recurring symptom and a profile that warrants a more complete picture. The CT angiogram shows a 40% narrowing in the left, anterior descending artery. Not critical. Not yet. But visible. Documented. Now being managed. If this had surfaced at level 1, if the ER 3 years ago had ordered a CT angiogram on someone without obvious emergency symptoms, it wouldn't have happened. Not because you didn't deserve it. Because that is not how emergency room resource allocation works. You are being managed. You are being watched. The thing inside you that could become a crisis has a name and a chart number, and a doctor who knows it exists. That's worth more than the statin. Level 6. $1 million. Once a year, you take 2 days off and go to a facility. Not a hospital. A facility. The kind with a name that appears on lists of the best executive health programs in the country. The kind where the reception area looks like a hotel and nobody makes you fill out a clipboard while standing at a counter. The 2-day assessment covers everything, not the 12-panel your previous doctor ordered. 50, including cancer biomarkers that a standard primary care physician wouldn't order without a specific reason to suspect something. A team of 7 physicians reviews your results together. Cardiology, oncology, neurology, endocrinology, gastroenterology. They discuss you as a whole system, not as a series of symptoms presented to separate specialists in separate rooms 3 weeks apart. The physician who delivers your summary is not the one who ran the tests. He is the one who synthesized them. Your left anterior descending narrowing, now in its 2nd documented year, has not progressed. The panel recommends continuing your current management, a slight upward adjustment to the statin, and a repeat angiogram in 18 months rather than 24. There is no chest pressure this year. There hasn't been any in 2 years because a plan was built, and the plan is being followed by people who know your full picture and speak to each other regularly. The cancer biomarker panel returns a PSA trend worth monitoring, not elevated, trending upward in a pattern they want to track. They schedule a 6-month follow-up. You drive home with a 12-page summary in a binder, every marker, every finding, every recommendation. A document that is also, in some sense, a record of who has been watching over you. Level 7. $5 million. You don't go to the facility once a year. The facility comes to you. A team is assigned to your care. Your cardiologist, your internist, your oncologist, your radiologist. These are not the doctors you call when something is wrong. They are the doctors you have regardless. Your cardiologist reviews your blood work every quarter, not because you reported a symptom, because that's the arrangement. While you're having dinner on a Tuesday, your internist is reading a study published that morning. She thinks of you. By Thursday, it's in your file. When a new study is published, linking a specific genetic marker to early-onset coronary artery disease, she calls. Not to alarm you, to tell you there's a test worth adding to your next blood draw. The test comes back positive for the marker. The treatment protocol is adjusted accordingly. A different statin at a higher dose, an accelerated monitoring schedule, an interventional plan, already prepared, already reviewed by 3 of the country's leading cardiologists who have been briefed on your case. That would activate if it became necessary. You will probably never need that plan. That's the point. Your private radiologist has reviewed every scan you've had in the past 4 years. not in isolation, in sequence. He tracks what changed between year 1 and year 3, in a way a radiologist reading your scan cold, without the sequence, without the baseline, cannot. Medicine at this level is not better treatment. It is a different kind of attention. The kind where someone is always thinking about you before you think to ask. Level 8. $10 million. There is a file, not a chart in a hospital system. A file, maintained by a dedicated team. Updated when new research is published that might be relevant to your profile. Cross-referenced against your genome. You had it sequenced 4 years ago. Your biomarkers, your imaging history, and your family history going back 3 generations on both sides. When you have a question about your health, you call one number. The person who answers is not a nurse or a scheduler. She is a physician who knows your file. When the arterial narrowing was first identified, the thing that started as a tightness in your chest that you Googled and closed the tab on, your team did not present you with a treatment plan. They presented you with 3. They explained the evidence base for each one. They asked which outcomes mattered most to you. You were not a patient in that meeting. You were a decision maker. A panel of 5 cardiologists reviewed your case. 2 flew in for the meeting, not because you were in danger, because you were paying for the kind of care where the best people in the field look at your file and tell you what they would do if it were their own heart. The intervention they recommended was minimally invasive. 3 days of recovery. The procedure was performed by a surgeon who has done it more than 400 times. You chose him specifically. You had time to choose. You had a team to help you choose. The thing that started as a tightness in your chest, the thing you were afraid to look up, is now a managed condition with a name, a history, and 5 of the world's leading cardiologists who know it personally. Circular return. Somewhere right now, someone has had chest pain for 3 days. They Googled it, closed the tab, Googled it again, closed the tab again. They know they should go to the doctor. They also know what that costs. They will wait 1 more day, then another. The symptom will ease slightly, and they will decide it was probably nothing. They will tell themselves they'll go if it gets worse. It will get worse. Not this week. Maybe not this year. But the artery is doing what it was already doing when they searched and closed the tab. Nobody is watching it. Nobody has named it. Nobody has built a plan around it. When it becomes a crisis, visible enough to justify 9 minutes of a doctor's time, they will go to the emergency room. A chest X-ray will come back normal. An EKG will come back normal. They will be told to follow up with a primary care physician. They will go home with a bill they can't pay and a condition that could have been found, named, and managed years earlier. Not because anyone failed them, because the system they had access to was not built to look for things before they become emergencies. And the system that is built for that, the one with the quarterly blood work and the 50 marker panels and the 5 cardiologist review, costs more than most people will earn in a year. The same chest pain, the same artery, the same body trying to tell someone something is wrong. The diagnosis at the bottom and the diagnosis at the top might be identical. The difference is when it's caught. The difference is who's in the room. The difference is whether you are a patient or a client. A patient is someone the system reacts to. A client is someone the system watches. Most people will spend their entire lives inside the first kind of medicine, never knowing the second kind exists. And the ones who do know will never go back to being the other kind. The system didn't change between those 2 people. The system just revealed what it always was,